Okay, let's unpack this. We know the brain's the command center, but it needs, well, a massive amount of power constantly. Today, we're really diving deep into the infrastructure behind that, the brain's vascular system. And this isn't just basic anatomy class stuff. We're talking about the ultimate high-stakes highway network, the cerebral vasculature. It's basically the blueprint surgeons use, when they're navigating inside the skull.
It really is. It's one of the most remarkable systems and unforgiving. The brain needs that constant blood flow, non-negotiable. Its survival just hangs on this incredibly intricate network, dense, redundant. It's all packed in there.
So our mission today.
Professional mastery. That's the goal. We need to get beyond just the basic terms. We're looking at the detailed surgical anatomy, the specific segment classifications, those rare but absolutely critical anatomical variants, and of course the clinical hazards, the surgical risks. These really define the difference between success and, well, devastating failure in the OR.
And we're working directly from advanced surgical texts for this, the actual roadmaps.
Exactly. The comprehensive guides, they detail the paired anterior and posterior circulations, the flow dynamics, the deep venous drainage, all of it. We're essentially trying to internalize the kind of knowledge needed to understand vascular pathology and intervention at, an elite level. Right. So to lay the groundwork, we have to remember the cranial compartment gets its blood from two major separate paired systems.
Okay.
First, the anterior circulation. That's supplied by the paired internal carotid arteries, the ICAs. And these handle, well, the bulk of the cerebral hemisphere's needs.
And then there's the posterior circulation. That's fed by the paired vertebral arteries, the VAs.
Correct. They come up the neck and then unite to form the single basilar artery. This system takes care of the brainstem, the cerebellum, and the posterior parts of the cerebrum.
The genius is how they connect, though.
That's the key. Both circulations contribute branches, and they form the circulus arteriosus, which most people know as the circle of Willis. It sits right there in the basal cistern, strategically placed. It creates this vital collateral pathway.
A safety net.
Precisely. And from that circle, the major arteries branch off to irrigate the hemispheres. The anterior cerebral arteries, ACA, middle cerebral arteries, MCA, and the posterior cerebral arteries, PCA. That redundancy, those collateral routes, that's the brain's primary protection if a major artery gets compromised, whether by disease or, sometimes necessary surgical clamping.
Okay, so the source material mentions three core ways surgeons get in there. Open approaches, both anterior like the penile and posterior like the retrosigmoid, and then endovascular approaches. Now, endovascular stuff, coiling, flow diversion, that seems to have really taken over for things like aneurysms, right? So why do we still need to master the open approaches in such detail?
That's a really important distinction in modern neurosurgery. You're right, endovascular techniques are fantastic for purely vascular problems, things you can fix right inside the vessel. But open surgery, it's still the standard when you need direct tissue handling or decompression. Think complex tumor resections, especially if the tumor is stuck to critical arteries, certain epilepsy surgeries, and microvascular decompression.
Like for trigeminal neuralgia.
Exactly. Relieving that nerve compression by an artery requires an open approach. You need direct visualization to actually move the vessel. So we master the open approaches because, frankly, for pathology involving the surrounding structures, it's often still the only solution. Tag 1.2, embryological anomalies and clinical relevance.
This is where it gets tricky with all the variations. The sources say embryological variants are surprisingly common. Maybe up to 20% of people have something. And crucially, they're linked to a higher risk of vascular problems like aneurysms. Why is that? What's the connection?
It really boils down to hemodynamics. Flow patterns. These variants mean blood flows in a way that's different from the standard setup, and that often creates unusual stress points or high-pressure zones on the artery walls. Over decades, that constant altered stress can weaken the vessel wall, and that can lead to an aneurysm forming.
Makes sense. So what's the most common one we need to know?
The big one, clinically, is the persistent fetal posterior communicating artery, or fetal PCOM.
Okay, a fetal PCOM. What does that actually mean in terms of blood flow?
Well, in about 20% of people, the PCOM artery stays large. It becomes the dominant supply route to the posterior cerebral artery, the PCA. Normally, the PCA's first segment, P1, gets a good, strong feed from the basilar artery, from the posterior circulation. But if you have a persistent fetal PCOM, the ICA circulation, the anterior system, effectively takes over that posterior supply job via the large PCOM.
So instead of two sources feeding the PCA.
Right. Instead of a balance between the basilar and the ICA, that posterior territory becomes mainly dependent on the carotid system. So if that patient then develops disease or blockage in their ICA, the consequences for the posterior circulation territory, like the visual cortex, are immediate and severe, much more severe than if they had a standard setup.
Wow. Okay. And then there are those really rare ones, the primitive connections that didn't disappear during development.
Correct. These are remnants from around the 4th to 5th month of gestation, and finding one unexpectedly during surgery is a true emergency. We're talking about persistent channels that link the carotid and basilar systems much lower down, far more proximally than the circle of Willis. Things like the persistent primitive trigeminal artery, otic artery, hypoglossal artery, or the proatlantal intersegmental artery. They're rare, but they exist.
And their presence just completely rewrites the flow map.
Completely. It makes any embolization or surgical clamping of the major arteries incredibly risky. Imagine clipping a proximal ICA in the neck, a standard procedure maybe. But if the patient have one of these primitive connections, you might inadvertently cut off the only blood supply to their entire brainstem and cerebellum.
Yeah.
You have to know they exist.
And within the anterior circulation itself, there's an ACA variant mentioned, a solitary azygos A2 segment.
Ah, yes. The azygos ACA. This is where the paired A2 segments, which normally run parallel in the interhemispheric fissure, fail to develop separately. So you end up with a single midline A2 trunk supplying both frontal lobes. It might be asymptomatic for life unless it gets compromised.
Yeah.
But the clinical hazard is huge.
Because if that one vessel goes down,
It's catastrophic. Occlusion, vasospasm after an ACOM aneurysm bleed, surgical injury. Any compromise to that single azygos trunk causes devastating bilateral ischemia. You're looking at severe neurological deficits in both frontal lobes, potentially even a vegetative state. It's a massive vulnerability.
okay, let's switch gears to the physical approach. Getting into the anterior circulation, say for MCA aneurysms or ICA lesions, the Pillay-Samaral approach is described as the workhorse. What are the key landmarks on the outside that guide the surgeon?
Right, the preterianal, sometimes called the frontotemporal or Sylvian approach. It usually starts with a curved skin incision. Typically, it begins just in front of the ear, the preterigal region, and runs up towards the upper forehead, often tucked just behind the hairline for cosmetic reasons. But the key tactical part is the access near the temporal bone. Starting pretragal ensures the surgeon can see and include the top edge of the zygomatic arch in their planning.
Why is getting that lower part of the temporal bone so important?
It's all about the angle of attack and minimizing brain retraction. By taking the bone flap low, incorporating that lower part of the temporal squama, the surgeon gets a much better, flatter trajectory towards the deep structures. It gives superior access into the Sylvian fissure, which you have to open to get to the MCA, and it provides a direct line of sight down to the basal cisterns where the ICA terminates. It's a critical maneuver for avoiding unnecessary pressure on the brain.
Got it. Now, flipping to the back of the head, for posterior fossa approaches near the skull base or cerebellum, what guides the surgeon there? It seems even more crowded.
It is dense back there. Precision is everything. You need reliable vertical and horizontal markers. Vertically, the starting point is usually the occipital protuberance, that bump you can feel on the back of your skull. It indicates the approximate level of the confluence of the venous sinuses, the torcula. Horizontally, you need to know where the transverse sinus is to avoid massive venous bleeding.
Oh.
You can approximate its level by drawing a line straight back from the zygomatic arch.
Okay.
And then lower down in the neck, the spinous process of the second cervical vertebra, C2, or the axis, is very easy to feel. It's a really reliable landmark for deep dissection, especially when you're trying to find that tricky V3 segment of the vertebral artery.
All right, let's really get into the anterior circulation now, starting with the ICA, the main supply line. Mastering this means knowing the segments, and the Giborphone classification C1 to C4 seems standard. Where does it start?
The ICA branches off the common carotid artery, usually around the level of the C3 vertebra in the neck. That first part running up the neck is the C1 segment, or cervical segment. This is the part surgeons often expose during, say, a carotid endarterectomy or neck dissection.
And there's a lot packed in there, isn't there? What's at risk?
Oh, absolutely. It's crowded. You have to meticulously watch out for the parotid gland, the hypoglossal nerve, CN12, controlling the tongue, the digastric muscle, various structures attached to the styloid process, and critically, branches of the vagus nerve, CNX, like the pharyngeal branch, and the glossopharyngeal nerve, CN2NIX. Damaging those can lead to serious problems with speech and swallowing.
Then the ICA dives into the skull base through the carotid canal.
That marks the beginning of the C2, or petrous segment. It's completely encased in the temporal bone. Its location is key clinically. It lies incredibly close to the middle ear cavity, the tympanic cavity, just anteriorly. And the cochlea, the hearing organ, is just posterior. Only thin bone separates them. That's why vascular tumors or anomalies here can cause pulsatile tinnitus hearing your pulse or affect hearing directly. It gives off a couple of small branches, the Vidian artery and the caroticotympanic artery, but they're usually minor.
As it works its way through the skull base, it gets surrounded by that big venous channel.
The cavernous sinus, yes, that's the C3, or cavernous segment. The ICA literally snakes its way through this venous lake. And because it's traveling alongside several cranial nerves within that sinus nerves, third, 4 days, 6, and parts of V1 and V2, this segment is a real hotspot for pathology.
Let's break down the branches coming off C3. They supply the dura and pituitary.
Primarily, yes. There are 3 main trunks off C3. The meningohypophyseal trunk, the infralateral trunk, and the medial trunk. The meningohypophyseal trunk is particularly important. It branches into the tentorial artery of Bernasconi and Casanari, which, as name suggests, supplies the tentorium cerebelli. It also gives off the inferior hypophyseal artery for the posterior pituitary gland, and the dorsal meningeal artery supplying the dura over the clavus.
Okay, and this leads to a really critical clinical point. Aneurysms popping up in the C3 cavernous segment, and also in the next little transitional bit, the clinoidal segment.
Yeah.
They're different. They're not inside the dura.
Fundamentally different, yes.
Right.
This is a crucial distinction for understanding risk, because these aneurysms are extradural, outside the dura mater, separated from the subarachnoid space. They cannot rupture and cause a subarachnoid hemorrhage, or SAH. That devastating brain bleed just doesn't happen from these locations.
So what is the risk then?
The main risks are different. They could rupture into the cavernous sinus itself, causing a high-flow connection called a carotid cavernous fistula. Or, more commonly, as they grow, they cause mass effect. They press on those cranial nerves trapped with them inside the sinus, especially the abducens nerve, CNVI, which controls lateral eye movement. That often leads to a sixth nerve palsy and inability to look outwards, knowing that extradural boundary is just. It's basic but life-saving information.
And the final step takes the ICA into the subarachnoid space.
Correct. Once it pierces the distal dural ring near the clinoid process, it becomes the C4 or supraclinoid segment. Now it's truly intradural. It's sitting in the carotid cistern, bathed in cerebrospinal fluid. And now if an aneurysm ruptures here, it will cause SAH, hashtag TAG 2.2, the intradural ICA and its major branches.
Okay, C4. This is where we see that characteristic S shape, the carotid siphon. What defines the surgical space right around it?
Well, the roof of the carotid cistern, the space where C4 sits, is formed by the anterior perforated substance. You can see it surgically. It's marked out by the medial and lateral olfactory striae. And we divide this C4 segment into 3 parts, based on where its major branches come off, moving from proximal to distal.
First up is the ophthalmic segment.
Right. This runs from where the ICA becomes intradural up to the origin of the posterior communicating artery, the PCOM. Its main branch, obviously, is the ophthalmic artery, which shoots forward into the orbit alongside the optic nerve to supply the eye. It also gives off the superior hypophyseal artery, which supplies the anterior pituitary gland.
Next, the communicating segment, home of the PCOM artery itself.
Yes, and this tiny vessel carries huge clinical weight. This segment runs just from the PCOM origin to where the anterior choroidal artery comes off. PCOM aneurysms, arising right here, are the absolute classic cause of a painful third cranial nerve palsy, oculomotor palsy.
Why is that connection so specific?
It's the nerve's path. CN30 emerges from the midbrain and travels forward, passing directly next to the PCOM origin. It's literally wedged in the small space between the posterior cerebral artery, PCA, behind it, and the superior cerebellar artery, SCA, below it. So an expanding aneurysm right at that PCOM junction puts direct pressure on the nerve. That causes the classic signs. Ptosis, droopy eyelid. A dilated pupil because the parasympathetic fibers run on the outside of the nerve and get hit first, and the eye looks down and out because the other muscles are unopposed.
Got it. And the last segment of C4 before the ICA splits?
That's the choroidal segment. It runs from the anterior choroidal artery origin up to the terminal bifurcation of the ICA into the MCA and ACA, and its namesake, the anterior choroidal artery, IDCA, is critical.
Small artery, big trouble if it's damaged.
Exactly. Its territory is disproportionately vital for its size. Its path is key. It runs back, passes underneath the optic tract, and then dives into the choroidal fissure to supply the choroid plexus. But along the way, its little perforating branches supply the anterior perforated substance, the optic tract, the uncus in the temporal lobe, and most critically, the posterior limb of the internal capsule.
The internal capsule, that's the superhighway for motor and sensory signals, right?
You absolute main conduit, so injury to the HOA or vasospasm affecting it after surgery or SAH can cause a devastating clinical triad.
Right.
Contralateral hemiplegia, motor loss, contralateral hemisensory loss, and contralateral homonymous hemianopia, visual field loss. Protecting the HOA is paramount in any surgery near the ICA bifurcation or involving the medial temporal lobe. It's non-negotiable. Hashtag tag 2.3 middle cerebral artery, MCA segments, M1, M4.
Okay, moving on. The MCA, the middle cerebral artery, it's the ICA's biggest branch, feeding the sides of the hemispheres. Let's map its segments, starting with M1.
Right, the MCA M1 segment, also called the synoidal segment. This is the initial horizontal part. It runs from the ICA bifurcation laterally towards the sylvian fissure, ending where it takes a sharp upward turn at the limen insulae, the threshold of the insula. And the crucial hazard here, the origin of the lateral lenticulostriate arteries.
Ah, the lenticulostriates. You hear surgeons talk about these with, well, a kind of reverence during sylvian fissure surgery. Why are they so absolutely critical?
Because they are end arteries with no significant backup supply, and they feed incredibly important deep structures. They peel off M1, go straight up, penetrate the anterior perforated substance, and supply vital deep gray matter nuclei. Specifically, the anterior limb, the genu, and a big part of the posterior limb of the internal capsule. Also the head of the caudate nucleus, parts of the putamen and globus pallidus.
So the main relay stations for motor control.
Precisely. High-speed relay centers. If M1 itself is injured, or if these perforators are stretched, torn, or clipped during surgery, the result is almost invariably a dense contralateral hemiplegia, paralysis on the opposite side of the body. A huge amount of surgical strategy during MCA aneurysm clipping revolves around gently mobilizing M1 and the next segment M2 without putting any traction on or, God forbid, sacrificing these perforators.
Okay. Past that turn at the limen insulae, the MCA heads up over the insular cortex.
That's right. Those are the M2 insular segments. The MCA usually splits into 2 or 3 main trunks here, often an anterior and a posterior division, which run across the surface of the insula. They give off small branches into the insula itself and the external capsule underneath. Yeah. Then come the M3 opercular segments. These are the branches that run tightly stuck to the underside of the lids, covering the insula, the frontal, parietal, and temporal operculi.
And finally, M4 cortical segments emerge onto the brain surface.
Yes, these are the branches we see spreading out on the lateral surface of the hemisphere after they emerge from the sylvian fissure. The largest M4 branches supply really important areas, like the temporo-occipital region and the angular gyrus region, involved in language and spatial processing. Clinically, these surface M4 branches are often the target vessels, the recipients, for ECIC bypass surgery. That's where surgeons connect a scalp artery to a brain artery if a major vessel upstream, like the ICA, has to be blocked off due to a giant aneurysm or tumor.
And clinically, thinking about subarachnoid hemorrhage again, the sources point to a pattern. If you see blood mostly clumped asymmetrically in the sylvian fissure on a CT scan, it's innate.
Your prime suspect is a ruptured middle cerebral artery aneurysm.
Absolutely.
The MCA is the biggest artery supplying the lateral surface, and its main trunk and initial branches are all contained within that sylvian fissure. So if one ruptures, the blood naturally pools right there, creating a very characteristic pattern that points the surgeon straight to the likely culprit. Hashtag tag 2.4 anterior cerebral ACA segments, A1, A5. Okay, the other main branch off the ICA is the ACA, the anterior cerebral artery. Its first part, the A1 segment, or precommunicating segment, runs towards the midline, usually above the optic nerve.
And the size variation in this A1 segment is really key for understanding ACOM aneurysms, isn't it?
It really is. Hypoplasia of one A1 segment, meaning one side is significantly smaller than the other, is very common. This creates uneven, asymmetric flow hitting the junction point, the anterior communicating artery, ACOM. That increased stress is strongly linked to why ACOM aneurysms form. And ACOM aneurysms are the single most common type of cerebral aneurysm overall. Also, perforating branches come off A1, the medial lenticulostriate arteries supplying the optic nerves, chiasm, and parts of the internal capsule.
The ACOM artery itself is that short bridge connecting the two ACAs, usually sitting just above the optic chiasm.
Yes, and the ACOM isn't just a connector. It also gives off its own tiny perforators. These supply critical midline structures like the pituitary stalk and infundibulum, the optic chiasm itself, and parts of the hypothalamus right above it. These can definitely be affected when a large ACOM aneurysm ruptures or is treated.
Okay, once we get past that ACOM junction, we're into the A2 segment, the infracalisal segment. This runs up towards the front of the corpus callosum, giving off branches like the orbitofrontal and frontopolar arteries. But the real star, or maybe the villain of the A2 segment, seems to be the recurrent artery of Hubner.
Ah, Hubner's artery. Yes, it has legendary status among neurosurgeons, mostly because it's so easily injured. It almost always arises from the very beginning of the A2 segment, sometimes even from the A1A com junction. But here's the tricky part. Instead of heading forwards with the main ACA, it makes a sharp U-turn and runs backwards, laterally, towards the anterior perforated substance. And its territory is functionally massive. It supplies the head of the caudate nucleus, parts of the putamen, and crucially the anterior limb of the internal capsule.
So if a surgeon is dissecting around a complex ACOM aneurysm, maybe one that's pointing downwards or backwards, Hubner is right there in the line of fire.
Exactly. It is arguably the single most common significant vessel injured iatrogenically during ACOM aneurysm surgery. If Hubner's artery is damaged or goes into vasospasm, the patient wakes up with a contralateral hemiparesis, but one that characteristically affects the face and arm more than the leg. They might also have expressive language problems, dysphagia. It's because that anterior limb supply to the motor pathways for the face and arm gets knocked out. That's why techniques like subpial dissection, staying right on the surface of the aneurysm sac, are used, specifically to identify and protect this tiny but vital vessel. Got it. The rest of the ACA segments, A3, A4, A5, basically follow the curve of the corpus callosum. That's right, they map its course. A3 is the precallosal segment, running up towards the knee. A4 is the supracallosal segment, running over the top. And A5 is the postcallosal segment, heading towards the back. Clinically, if the entire ACA territory gets compromised, maybe from vasospasm or a clot, the result is very different from an MCA stroke. The ACA supplies the medial surface of the frontal lobe and a strip along the top. That medial part contains the motor cortex representation for the legs and pelvic muscles. So ACA ischemia typically causes severe lower limb weakness, sometimes urinary incontinence. If the supplementary motor area also supplied by ACA is hit, you can see problems with initiating movement, apraxia, or speech disturbances.
Okay, let's shift focus now. Back of the brain, the posterior circulation. It all starts with the vertebral artery, the VA. V1 is before it enters the spine. V2 is the foraminal segment, traveling up through those holes in the cervical vertebrae, C6 up to C2.
Right, and that V2 segment is important functionally because it gives off small branches, the radiculomedullary arteries, that feed into the spinal cord's blood supply in the neck, connecting with the anterior spinal artery system.
Then we hit V3, the extradural, extraspinal segment. This one sounds particularly tricky and high risk during surgery back there. Why the complicated path?
V3 is, let's say, anatomically adventurous. It comes up through the transverse foramen of C1, the atlas. Then it makes a sharp turn backwards to lie in a groove on the top of the posterior arch of C1. After running along that groove, it turns sharply forwards again to pierce the tough atlanto-occipital membrane and the dura mater, finally becoming the intradural V4 segment. It's these sharp turns right at the craniocervical junction that make it so vulnerable, especially during far lateral or extreme lateral approaches to the posterior fossa or skull base. One wrong move, and you have massive arterial bleeding right at the entry point to the skull.
The sources give a very specific anatomical landmark check for V3 related to the suboccipital triangle. Can you walk us through that? It seems critical for safety.
Yes, this is vital surgical anatomy. The V3 segment, as it loops around the C1 arch, lies within the boundaries of the suboccipital triangle. This small triangle is formed by three deep muscles: the superior oblique, the inferior oblique, and the rectus capitis posterior major. These muscles define the space where the artery lives. But crucially, the large semispinalis capitis muscle lies superficial to this triangle, covering it like a roof. So when a surgeon is dissecting down from the surface, identifying the semispinalis capitis tells them they are still dorsal, still superficial to that critical triangle containing V3. It provides a vital safety layer, preventing accidental catastrophic injury to the vertebral artery. Understanding these layers is key.
And then V4 is the final bit, the intradural segment. It heads up and towards the midline.
Correct. V4 travels anterosuperiorly, passes through the foramen magnum, and then meets its partner from the other side, right at the junction between the pons and the medulla, to form the basilar artery. Before joining, V4 typically gives off the posterior spinal arteries, usually paired, and contributes to the single anterior spinal artery that runs down the front of the spinal cord. It's also the most common origin for PICA, the posterior inferior cerebellar artery, #tag 3.2 basilar artery.
Right, the basilar artery, the great midline trunk running up the front of the pons. It's supplying the whole brainstem, essentially, before it splits at the top.
Exactly. It forms at the ponomedullary junction and travels up the basilar groove on the anterior of the surface of the pons, terminating near the pontomesencephalic junction where the pons meets the midbrain, and the perforating arteries coming directly off the basilar. These are, well, absolutely sacrosanct, non-negotiable preservation.
Why so critical? More so than other perforators.
Because of what they supply. They're divided into medial and circumflex perforators, and they dive directly into the pons, supplying the pontine nuclei and all the critical ascending and descending white matter tracts running through there. Injury to any basilar perforator, even a tiny one, carries an incredibly high risk of catastrophic locked-in syndrome or other devastating brainstem strokes. The density of vital functions in that small area is just immense. There's no room for error.
And the major named branches off the basilar are the three paired cerebellar arteries, AICA, SCA, and then the terminal split into the posterior cerebral arteries, the PCAs, #tag 3.3, the cerebellar arteries, PICA, AICA, SCA.
Okay, let's tackle the cerebellar arteries. We have to start with PACA, the posterior inferior cerebellar artery. It's notorious. Why? Because it has, hands down, the most tortuous, complex, and variable path of almost any artery in the brain. It usually comes off V4 just before the basilar formation, but its origin can vary.
The sources break PICA down into 5 surgical segments because its route is so complicated, wrapping around the brainstem and cerebellum.
That's right. We talk about the anterior medullary, lateral medullary, posterior medullary, suprathalamus, and finally the cortical segments. What really characterizes its complexity are its loops. It often forms a significant caudal loop near the medulla, which can dip down near or even below the foramen magnum. And then it typically forms a rostral loop, also called a choroidal point or cranial loop, higher up in the suprathalamus segment near the roof of the fourth ventricle where it supplies the choroid plexus. Its variability means you absolutely need detailed preoperative imaging like a CTA or MRA to map it out before any surgery near the cerebellar tonsils or fourth ventricle.
Okay. Next up, AICA, the anterior inferior cerebellar artery.
AICA usually arises from the lower half of the basilar artery. Its surgical significance is all about its incredibly close relationship with the cranial nerves emerging from the pons, specifically in the cerebellopontine angle CPA. The lateral pontine segment of AICA runs right alongside, often looping around, the facial nerve, CNS7, and the vestibulocochlear nerve, CN8.
So during surgery for things like acoustic neuromas in the CPA.
Exactly. The surgeon has to be exquisitely careful when mobilizing the tumor off these nerves to identify and preserve the AICA loop. Stretching or damaging AICA here can easily cause permanent facial paralysis or hearing loss. Also, the labyrinthine artery, the main supply to the inner ear, usually branches off AICA, adding another layer of risk to hearing preservation.
And the last of the cerebellar trio, SCA, the superior cerebellar artery.
SCA is generally considered the most constant and predictable of the three. It arises right from the top of the basilar artery, here its bifurcation into the PCAs. Its key anatomical relationship, diagnostically, is with the oculomotor nerve, CN3. The SCA runs inferior to CN3 as the nerve merges from the midbrain. However, the SCA often forms a loop downwards, a caudal loop, that frequently comes into contact with the root entry zone of the trigeminal nerve, CNV, where it enters the pons.
Ah, so that's the connection to trigeminal neuralgia.
That's the most common culprit. Vascular compression by the SCA loop irritating the trigeminal nerve root is the underlying cause in many cases of classic trigeminal neuralgia. Therefore, the SCA is the vessel most often targeted in microvascular decompression, or MVD surgery for this condition. The surgeon's goal is to gently lift the SCA loop off the nerve and place a small Teflon sponge between them. #tag 3.4 posterior cerebral artery PCA segments, P1, P4.
Okay, finally, the PCAs, the posterior cerebral arteries, branching off the top of the basilar. P1 is the first bit, the pre-communicating segment.
Right. P1 runs from the basilar bifurcation laterally towards the PCOM junction, and its critical contribution is giving off the thalamoperforating arteries. These are deep, vital perforators supplying the thalamus, the subthalamus, the substantia nigra, the red nucleus, the nucleus of the oculomotor nerve itself deep in the midbrain, and also parts of the posterior limb of the internal capsule. Occlusion here causes complex midbrain and thalamic stroke syndromes.
And this is where that embryological variant, the fetal PCOM, comes back into play again surgically, right? Affecting the size of P1.
Precisely. Remember that 20% of people where the PCA gets most of its blood from the ICA via a large dominant PCOM. In those individuals, the P1 segment coming off the basilar will be very small, hypoplastic. This is critical knowledge for a surgeon. If they're planning to treat a lesion on P1, maybe clip an aneurysm there, assuming it has robust flow from the basilar, they could be tragically wrong. If that P1 is hypoplastic because of a fetal PCOM, clamping it could inadvertently compromise the entire PCA territory, which is actually being fed from the front via the ICA. You have to assess the PCOM size and contribution.
Got it. Moving on, P2 is the post-communicating segment. It has a more complex path through the cisterns around the midbrain.
It does. P2 is often divided into P2A, anterior part in the crural cistern, and P2P, posterior part in the ambient cistern. P2A runs above the edge of the tentorium and the trochlear nerve, CNIV. P2P continues posteriorly, wrapping around the midbrain. Key branches off P2 include inferior temporal arteries, supplying the bottom of the temporal lobe, and crucially, two posterior choroidal arteries, a medial and a lateral one. These supply the choroid plexus in the third and lateral ventricles and parts of the thalamus and brainstem. Surgeons need to be very careful around P2, especially during resections of medial temporal lobe tumors that push down towards the tentorium to avoid injuring these branches and causing visual field deficits or memory problems.
And the final segments, P3, quadrigeminal, and P4, cortical, head towards the occipital lobe.
Exactly. P3 runs over the top of the midbrain tectum near the quadrigeminal plate. And P4 is essentially the terminal cortical branching, ending near the calcarine sulcus, where the PCA typically splits into the calcarine artery and the parieto-occipital artery. These key four branches supply the primary visual cortex on the medial aspect of the occipital lobe. So ischemia in the PCA territory classically causes contralateral homonymous hemianopia loss of the same half of the visual field in both eyes.
Okay, we've meticulously mapped the incoming highways, the arteries. Now we need to understand the return trip, the venous drainage, the low-pressure system. Our sources really stress that knowing the venous anatomy is just as critical for surgical safety, even though it's often given less attention in basic studies.
That emphasis is absolutely right, and often learned the hard way. Unlike arteries, veins have thin walls. They often bridge across spaces like the subarachnoid space or between dural folds. This makes them really susceptible to tearing from traction during craniotomy, brain retraction, or even just raising the bone flap. So knowing the drainage patterns is key for planning safe bone removal, for working inside the ventricles, and also for understanding how infections might spread within the head. We usually divide the system into two main groups: the superficial group, draining the brain surface, and the deep group, draining the ventricles and central structures. Hashtag 4.2 superficial venous group and dural sinuses.
Let's start at the top, literally with the biggest one, the superior sagittal sinus, SSS.
Right. The SSS runs right along the midline in the top edge of the falx cerebri, that dural fold separating the two hemispheres. It gets progressively larger as it goes back, collecting blood from bridging veins from both hemispheres. It usually drains predominantly into the right transverse sinus of the back, but that's variable. There's a critical surgical safety rule here. Generally, the SSS can be safely ligated or occluded anterior to the coronal suture.
Why is it safe up front, but not further back?
It's about the volume and consistency of drainage. The bridging veins draining into the very front part of the SSS are typically fewer and smaller, and there's often enough collateral drainage through the deep venous system to compensate if that anterior part is blocked. But once you get behind the coronal suture, the bridging veins become much larger and more numerous. Occluding the SSS back there carries a much higher risk of causing massive venous congestion, swelling, and infarction in both hemispheres.
Okay. Lower down in the falx, there's the inferior sagittal sinus, ISS.
Yes. The ISS runs along the free, curved lower edge of the falx. It drains the deep medial parts of the cortex, especially the limbic lobe structures, like the cingulate gyrus. The ISS then flows backwards and meets the great vein of Galen from the deep system to form the straight sinus. And the straight sinus typically drains predominantly into the left transverse sinus. This asymmetry often means the left transverse sinus is smaller than the dominant right one.
Speaking of asymmetry, the transverse sinuses themselves running sideways at the back and the sigmoid sinuses curving down from them, they vary a lot too.
Hugely variable. As we said, the right transverse sinus is usually larger, getting that main SSS flow. But surgeons must check preoperative imaging, like an MR venogram, because partial or even complete agenesis absence of one transverse sinus happens in maybe 20% of people. You absolutely do not want to mistake an absent sinus for one that's just compressed by a tumor and try to open it. That would be catastrophic, bleeding into a blind pouch.
Okay, trace the path to the exit. Where does it all finally drain out of the skull? The jugular junction.
Right. The sigmoid sinus makes that S-shaped curve downwards through the mastoid part of the temporal bone. It then reaches the jugular foramen, a hole at the skull base. Right there at the posterolateral part of the foramen, called the pars vascularis, the sigmoid sinus joins up with the inferior petrosal sinus, which drains the cavernous sinus. That meeting point is the beginning of the large internal jugular vein, IJV, which then carries the vast majority of the brain's venous blood back down the neck towards the heart. Hashtag 4.3 inferior superficial group and key anastomoses.
All right, the inferior group. The cavernous sinuses are central here, those paired structures on either side of the pituitary fossa, sella turcica. They drain backwards via the petrosal sinuses.
Correct. They drain mainly via the superior and inferior petrosal sinuses. The superior petrosal sinus runs in a groove along the top ridge of the petrostotemporal bone, essentially marking the boundary between the middle fossa, supratentorial, and the posterior fossa, infratentorial. Importantly, it receives bridging veins from the cerebellum and brainstem, sometimes called the superior petrosal veins of Dandy. These veins can act like tethers, limiting how much a surgeon can mobilize the cerebellum during retrosigmoid or lateral approaches to the posterior fossa. They have to be respected or sometimes very carefully coagulated and divided if absolutely necessary.
And the main vein draining the Sylvian fissure region where the MCA lives.
That's the superficial Sylvian vein. It courses along the fissure. Its drainage is variable, but it most commonly drains forwards and medially into the sphenoparietal sinus, also known as the sinus of Brachet. The small sinus runs along the underside of the lesser wing of the sphenoid bone and empties into the front part of the cavernous sinus. During a peritoneal approach, surgeons often need to carefully dissect and sometimes temporarily clip or divide this vein to get deeper access to the M1 segment. But preserving its flow if possible is important to avoid venous congestion in the temporal lobe.
Okay, and then there are the big three anastomotic veins connecting different parts of the superficial system. They provide backup drainage.
Exactly. They provide crucial collateral pathways on the brain surface. Their exact location and size vary hugely between individuals, but they are almost always present in some form. First, the superior anastomotic vein, better known as the vein of Trollard. This is often the largest vein on the upper lateral surface. It connects the superficial Sylvian vein upwards to the superior sagittal sinus. It typically runs across, or very close to, the central lobe near the motor and sensory strips.
Making it critical to preserve.
Absolutely mandatory. Sacrificing a dominant vein of Trollard can cause devastating venous infarction of the motor strip, leading to severe paralysis. Second, the inferior anastomotic vein, universally known as the vein of Labbé. This is usually the largest vein bridging downwards. It connects the superficial Sylvian vein across the temporal lobe to the transverse sinus. The vein of Labbé is the critical drainage pathway for the posterior temporal lobe and adjacent areas. Preoperatively assessing which of these two, Trollard or Labbé, is dominant in a particular patient can actually help decide whether a more frontal or more temporal surgical approach might be safer for certain lesions to avoid compromising the main viral outflow pathway. Hashtag 4.4 deep venous group, intraventricular and cisternal. Okay, moving deeper now. The deep system drains the core of the brain, the ventricles, the basal ganglia, the thalamus. It all funnels towards the center, towards the internal cerebral veins and the great vein of Galen. That's the basic plan, yes. Numerous small veins within the walls of the ventricles coalesce into larger named vessels, which ultimately lead towards the midline. Probably the single most important intraoperative landmark within the deep system, especially when working inside the lateral ventricles, is the thalamostriate vein, TSV. It starts in the groove between the thalamus and the caudate nucleus in the floor of the lateral ventricle. It runs forwards and medially towards the foramen of Monro, the opening connecting the lateral and third ventricles. Right at the foramen, the TSV makes a characteristic sharp hairpin turned backwards to drain into the internal cerebral vein. That sharp turn, the venous angle, is a critical landmark. It tells the surgeon they're right at the foramen. Going anterior to that risks damaging structures in the septum pellucidum or fornix.
And the TSV drains into the paired internal cerebral veins, ICVs.
Correct. The two ICVs run parallel to each other in the roof of the third ventricle, within a thin membrane called the velum interpositum. They then travel backwards under the splenium, the back part of the corpus callosum, where they unite to form a single large trunk, the great vein of Galen, or vena magna cerebri. This is the central confluence point for the entire deep venous system.
What about drainage from structures below the ventricles, like the basal ganglia?
That's handled primarily by the paired basal veins of Rosenthal. These are important veins that start down near the anterior perforated substance below the front part of the basal ganglia. They then take a long, curving path posteriorly, running in the groove between the cerebral peduncle of the midbrain and the medial temporal lobe, hippocampus. Their termination point is crucial. They usually swing medially and drain directly into the great vena galen and the quadrigeminal cistern, right where the ICVs also join. Surgery anywhere near the vena galen is extremely hazardous. Occlusion or thrombosis of the galen can cause massive, often fatal, deep venous infarction affecting the thalamus, basal ganglia, and upper brainstem bilaterally.
And briefly, the veins draining the posterior fossa itself, the cerebellum and brainstem.
That's the infratentorial venous system. It's generally divided into three groups based on where they drain: superior, anterior, and posterior. The superior group drains the top surface of the cerebellum and upper brainstem, often heading towards the great vein of Galen. The precentral cerebellar vein is a major vessel in this group, running in the fissure between the cerebellum and midbrain. The anterior group drains towards the petrosal sinuses. The posterior group drains the inferior cerebellum and vermis, with the inferior vermian vein being a major collector, often draining into the tentorial sinuses or the straight sinus. Damaging these major cerebellar veins during posterior fossa surgery can lead to significant cerebellar swelling, edema, and serious postoperative neurological problems.
Okay, we've covered a massive amount of anatomical detail. Let's try to synthesize and really highlight the absolute do not injure structures, the ones whose compromise leads to the worst outcomes.
Good idea. Let's consolidate the danger zones. In the anterior circulation, the two big arterial ones we stressed are, first, the recurrent artery of Hübner, especially during ACOM aneurysm surgery. Techniques like careful subpial dissection are aimed squarely at preserving it. Injury leads to that characteristic face-arm-like hemiparesis, baby dysphagia. Second, the lenticulostriate perforators off the MCA's M1 segment, vital for the internal capsule's motor pathways. Damage from retraction or clipping during MCA surgery almost guarantees a severe hemiplegia. They are untouchable.
Moving to the posterior circulation, the risk seems centered on the brainstem itself.
Absolutely. The basilar artery perforators. These are, without exaggeration, sacrosanct. Any injury carries an extremely high risk of devastating brainstem infarction. They are non-negotiable. Also, in the posterior fossa generally, the intimate relationship between the cerebellar arteries Pisceae, ACA, sometimes SCA, and the lower cranial nerves, 9XX, ELF, and the facial vestibulocochlear nerves is critical. Careful microscopic dissection is needed to separate vessels from nerve root entry zones to prevent palsies affecting swallowing, voice, facial movement, or hearing.
And the critical venous structures to protect.
The great vein of Galen is top of the list. Compromising flow here is potentially catastrophic due to risk of deep central venous infarction. The major cortical bridging veins, especially a dominant vein of Gerard or vein of Labbe, must be preserved to avoid disabling venous infarcts in critical cortical areas like the motor strip or language areas, and the major dural sinuses, particularly the superior sagittal sinus posterior to the coronal suture, and the transverse sigmoid sinuses. Preoperative assessment of their patency, often with MR or CT venography, is mandatory before tackling tumors like parasagittal meningiomas that might involve the sinus, to know if it's safe to sacrifice or if complex reconstruction is needed. Hashtag 5.2 Synthesizing Clinical Presentation with Anatomy.
This is where it all comes together, connecting the patient's symptoms or the imaging findings directly back to the specific anatomy we've discussed. Let's quickly review those SAH patterns on CT again.
Right. The location of the densest blood clot is your best first clue to the source aneurysm. If the blood is thickest, really packed into the sylvian fissure on one side, think MCA aneurysm. If the hemorrhage is predominantly a midline, right in the interhemispheric fissure between the frontal lobes, suspect an ACOM or distal ACA aneurysm. And if the blood is primarily down low, filling the basal cisterns around the midbrain and pons, your top suspects are PCOM, basilar apex, or maybe SCA aneurysms.
Okay, let's use those clinical examples from the outline to drive this home. Example 1. A patient has surgery or coiling for an ACOM aneurysm and afterwards develops a new left hemiparesis, mostly affecting the lower limb, maybe with some apraxia or difficulty initiating actions.
Okay, the localization there is classic anterior cerebral artery, ACA territory. The motor cortex controlling the leg and pelvic area is on the medial surface of the frontal lobe, right in the ACA's distribution. The fact that the face and arm, MCA territory, are relatively spared points away from the lenticulostriates or MCA itself. So the injury, whether it's direct surgical damage, vasospasm affecting the A1 or A2 segments, or maybe compromising Hübner if the weakness pattern fits, has hit the ACA supply. The apraxia also fits nicely with damage to the supplementary motor area, also supplied by the ACA.
Perfect. Example 2. The patient presents with a sudden onset, isolated, painful third cranial nerve palsy. They have a sectosis, a dilated pupil, and their eye is looking down and out.
That clinical picture screams posterior communicating artery, PCOM, aneurysm. It's almost pathognomonic. We know the oculomotor nerve, CN3, exits the midbrain and passes right through that small space between the PCA and SCA, immediately adjacent to where the PCOM arises from the ICA C4 segment. An expanding aneurysm at that specific ICA-PCOM junction compresses the nerve fibers hitting the outer parasympathetic fibers first, causing pupil dilation, and then the motor fibers. The pain likely comes from irritation of surrounding dura or the nerve sheath itself. This specific clinical sign is so reliable, it allows neurosurgeons to strongly suspect a PCOM aneurysm, often even before they see the scans. It's a direct anatomical correlation. Hashtag tag outro.
Well, we have covered an incredible amount of ground today. We've really aimed for that professional level mastery of the cerebral vascular system, mapping the critical segments of the ICA, MCA, ACA, the vertebrobasilar system, PICA, and not forgetting the equally vital venous return pathways. Understanding the Geber-Roten segments, knowing which perforators are absolutely non-negotiable, respecting those venous territories. It really feels like this knowledge is the core difference between safe surgical navigation and, well, potential disaster.
It truly is, and what always strikes me as fascinating here is how much the embryology dictates vulnerability later in life. Those variations we talked about, the 20% with the fetal PCOM, the rare azygos ACA, these aren't just anatomical curiosities. They establish inherent points of mechanical weakness or altered flow patterns that can directly lead to aneurysms or make strokes more likely decades down the line. We're essentially studying the long-term consequences of rules written during the first few weeks of development. Anatomy really is destiny sometimes.
That's a great point. Okay, final thought for our listeners. We made a point earlier that aneurysms in the cavernous segment, C3 of the ICA, can't cause subarachnoid hemorrhage because they're extradural, but let's push that connection between anatomy and function one step further. Given that the cavernous sinus contains cranial nerves, THR, 4, V1, V2, and CDS, think about this. What would be the specific comprehensive neurological picture, the combination of symptoms you'd expect from a large, slowly growing aneurysm located entirely within that C3 segment, assuming it doesn't rupture into the sinus? What constellation of cranial nerve problems and maybe facial pain syndromes would that relentless, expanding pressure inside the cavernous sinus produce? It forces you to connect that precise C3 anatomy to the function of everything packed tightly around it, something to mull over.